It's my pleasure right now to introduce Professor Liu for the presentation of CEUS diagnosis of new hepatic nodules in patients with colorectal cancer during chemotherapy. And warmly welcome Professor Liu for your presentation.
Thank you very much, Professor Christoph. It's really my honor to be here to introduce my recent study. Today, I'd like to share our experience by the contrast ultrasound in the diagnosis of newly detected small focal liver lesion in the patient with colorectal cancer during the chemotherapy. First of all, I'd like to introduce my hospital. I used to work in the first affiliated hospital of Sun Yat-sen University. At that time, it has been 7 years ago, so I mainly studied primary liver cancer. And after I transferred to the new hospital, this is the 6th affiliated hospital. We are the GI hospital of the Guangdong province. So we perform over 4,000 cases of colorectal cancer surgery every year, and this year it might be 5,000 cases. So we are the largest GI hospital in China. And as we know, the colorectal cancer has a really increase in China, and the liver metastasis there might be happened in more than half of the patients. So chemotherapy, systematic chemotherapy is really important to treat, is a very important way to treat for this patient, and is recommended for the advanced or metastatic patient. But chemotherapy, these drugs kills the cancer, but at the same time, it damages the liver. So stenosis and cyanoid injury happened quite often. As we know, this is a process, and the pathological changes damaged by the drugs. So I will not explain it here because time is limited. And we can see the chemotherapy-related liver injury may be separated into two types. The first one is diffuse, so the liver function damage, and also may increase the complication and the mobility during or after the surgery. And the other type of chemotherapy-related liver injury, it might present it to be the focal lesions. It's sometimes very similar to the liver metastasis, and maybe leading to the unnecessary biopsy or the surgery. So we have to take very careful about this kind of lesions to discriminate from the liver metastasis. And as we know, nowadays the imaging study is very important for the liver evaluation. So this paper compared the 5 modern imaging studies about the diagnosis of colorectal liver metastasis. We can see the intraoperative contrast ultrasound is presented the higher risk accuracy and the sensitivity. Contrast ultrasound presented similar ability with the contrast CT, and the CEMI might be better than contrast ultrasound. But we can see after post-chemotherapy, all of the imaging modality, the diagnosed ability decreased, especially for the contrast CT. We can see that it presented a significant difference after the chemotherapy. The diagnostic ability decreased significantly. So we performed a study to evaluate the diagnostic performance of the contrast ultrasound for the focal chemotherapy-induced focal lesions, and how to improve our diagnostic protocol for the newly detected lesions during the chemotherapy. So we finally included 43 patients all the patients performed the contrast ultrasound and the contrast CT or MRI within 1 week, and all the focal lesions has been confirmed by the histopathology diagnosis. We are using the Logic E9 for the contrast ultrasound, and for the lesion deeper than 6 centimeter from the skin, we will using the convex probe. But for the lesion located shallower, very within 6 centimeters from the skin, we will using the high frequency linear probe, the 9L probe for the contrast ultrasound, and we are using the SonarView for the contrast agent. And we can see there are total 16 chemotherapy-induced focal lesions in this study were founded, and there are 27 colorectal liver metastasis patients. So we can see, except the ALT and the AST presented the difference, because in this group, after the chemotherapy, it caused liver damage, and the other we can only see the other presented difference is the chemotherapy drugs. So in the chemotherapy-induced focal lesion group, we can see most of the patients used the oxaliplatin, these drugs for the chemotherapy. And this is the contrast ultrasound features of the different two types of lesions. In the arterial phase, 100% of liver metastasis presented hyper-enhancement, but for the chemotherapy-related lesions, there are almost 70 patients presented ISO enhancement, and only 20% of the lesion presented slightly hyper-enhancement. This is a very significant difference in the arterial phase. And the other, the enhancement pattern, we can see 70% of liver metastasis presented peripheral enhancement, rim-like enhancement, and another 1/3 of patients performed homogeneous enhancement. But for the chemotherapy-induced lesions, we can see 80% of the lesion presented heterogeneous enhancement. And for the enhancement time, we can see the time to peak liver metastasis was significantly faster, and the peak intensity was lower in the chemotherapy-induced lesions, and all the lesions washed out to be hypoenhancement in the portal and late phase. As for the CECT features of these two types of focal lesions, we can only see the shape in the portal phase presented a significant difference. And for CEMI, it is the same. Only the margin, in the portal phase, the chemotherapy-induced focal lesion presented a very ill-defined margin, but the liver metastasis presented a very well-defined margin. This is a difference of these two types of lesions on CEMI. So let's look at the diagnostic performance. We can see the contrast ultrasound presented the higher risk accuracy and higher risk diagnostic performance compared with CT and MRI, concerning by this with concern to the discrimination between the liver metastasis and the chemotherapy-induced lesions. So let's see some cases. This is a female patient, and after 8 cycles of chemotherapy, and we can see on the regular follow-up of CT scan, we found a very small lesion in segment 7 and slightly hypoenhancement in portal phase. So we cannot diagnose it according to the CT findings. So we performed the contrast MRI, and we can see T1 is slightly hypo, T2 slightly hyper, and there's no high signal intensity on DWI. And the contrast, we can not see hyper enhancement arterial phase, but slightly wash out in portal and late phase. The diameter of the lesion is 9 millimeter. And let's look at the contrast ultrasound. We can see there is a slightly hyperechoic lesion on baseline ultrasound. And after injection of the contrast agent, we can see this area, there's no hyperenhancement. But in the protophase, and it was slightly washed out, this area. So this is the first case we met for the chemotherapy-induced focal lesion. So we performed the biopsy. We can see there's no evidence of a liver metastasis. And on the regular follow-up, the lesion disappeared after 3 months of the diagnosis. And let's look at the second case. This is also the male patient. After 8 cycles of chemotherapy, we found a washout, a small lesion on CECT, and on baseline ultrasound, we found a very hyperechoic lesion, and on the contrast ultrasound, it is the same. There is no hyperenhancement in arterial phase, and but it washed out. Not so fast, not so sharp washout, but it washed out in portal and late phase slightly. So we perform biopsy again. It is not there is no evidence of liver metastasis. The pathologist said it is liver damage by the chemotherapy. And this case is a even smaller lesion. We can only find it on the portal face of the CECT. It's very close to the liver surface, and on CEMI, it is also not so typical lesion to diagnose. And we can see on baseline ultrasound, the lesion is a slightly hyperechoic with very ill-defined margin. And after we injected the contrast, we can see there is no hyperenhancement or slightly hyperenhancement, but it washed out very slowly. And this is in portal phase 30 seconds, we can see this area is slightly washed out. And so we perform the biopsy, we can see it is again the chemotherapy-induced focal lesion. And let's look several cases of the liver metastasis. So we can see here is a 10 millimeter lesion. By using the high frequency linear probe, we can see the detail very clearly, the contrast wash in and wash out. And in the portal phase, by using the linear probe, we can see very small lesion. It's only 5 millimeter in diameter, located very shallow to the liver surface, but we can find it very clearly. And our study has been published on the UMB, and if you are interested, please download the paper. And also this case is a colorectal cancer patient, and we found a very small lesion on the segment 4. And we performed the contrast ultrasound. We can see the peripheral rim-like hyperenhancement and very fast and clear washout in the portal phase. So we performed the biopsy. So this lesion was proved to be a liver metastasis. So as we can see, the diagnosis of chemotherapy-induced focal lesion is very difficult. We have to perform the biopsy to confirm the diagnosis, and the clinical symptom and the laboratory examinations will not help us the diagnosis, and also the contrast ultrasound findings has not been fully investigated. We found some paper reported the CT and MRI for the diagnosis of the chemotherapy-induced focal lesions. The CEMRI presented a very good diagnostic ability. It defined very different findings with the colorectal liver metastasis. But contrast ultrasound is a real-time and very high spatial resolution and very convenient, easy to use, and free of radiation. So I think contrast ultrasound is a really very good modality to diagnose this kind of lesions. So let's summarize. The diagnosis of chemotherapy-induced focal lesion, we can not see hyper-enhancement in arterial phase. So in arterial phase, the enhancement always be heterogeneous. And in portal and late phase, the lesion will wash out, just like the metastasis. It presented very clear hypo-enhancement area. But for the liver metastasis, we can see very clearly hyper-enhancement, no matter it is a rim-like or homogeneous enhancement. But we can see the hyper-enhancement very clearly, and also very quick and clear washout in portal and the late phase. So our study have some limitation because the cases are very limited, and also the patient accepted different chemotherapy cycles and also protocols, and also only part of patient performed both CT and CMI. Let's come to the conclusion. We think the radiologist should consider the chemotherapy-induced focal lesions for the newly detected focal liver lesions in patients with colorectal cancer after chemotherapy, because it is really easy to be misdiagnosed as liver metastasis. By using the contrast ultrasound, it may help us to improve the diagnosis of chemotherapy-induced lesions, because we cannot see hyper-enhancement in arterial phase, and this is very important for the differential diagnosis. And we think the contrast ultrasound should be conventionally recommended for the patient with colorectal cancer patient and chemotherapy. Thank you very much for your attention.
Yeah, thank you so much. Big applause for this excellent talk, and that you also stayed in time. So I received 2 questions from the audience, and if I'm allowed to read the first question. What are the most common chemotherapy-induced liver lesions?
I think it's the 4-FOX and 4-FIRI, especially the when we using the drugs of. Can you see my desktop? This kind of irritica will induce the stenosis, and oxaliplatin will induce the cyanoid injury for the patient. And also, incidence is very high. More than half of the patients accepted this kind of drugs may present a liver injury.
Yeah, perhaps I did not pose a question correct, and you answered that FOLFOX is the chemotherapy agent most commonly inducing focal liver lesions. But the question was, what are the most common chemotherapy-induced liver lesions?
I think that these two drugs may induce the liver injury, because all the drugs are used by combination in the clinical practice. In our hospital, sometimes we combine 2 different chemotherapy drugs. Sometimes we even 3 different kinds of chemotherapy drugs for the patient. So the protocol of the chemotherapy is quite different from patient to patient. But these 2 kinds of drugs may induce the liver injury in the clinical.
Thank you so much.
Yes.
Second question, does chemotherapy-induced liver lesions should question the chemotherapy itself or a modification of the protocol, in your opinion? So if we see such a lesion, should we change our protocol?
No, we won't change the protocol, because the protocol may it presents very unless we are evaluating the chemotherapy protocol by using the RECIST criteria. Only if the tumor presents resistant to the chemotherapy protocol, we will change our protocol. In case of the chemotherapy-induced focal lesion, we will not change the protocol, because it presented very few harm for the patient.
Thank you. Third question. What is the
Thank you.
time frame to see or suspect these lesions during or after chemotherapy?
In our experience, about most of the patients will present liver injury after 6 to 8 cycles of chemotherapy.
So all three questions are nicely answered. You did an excellent presentation and discussion. Thank you again. And
thank you very much.